I spoke about blood pressure management in extremely preterm infants, and I think the take-home messages are that blood pressure is one parameter that we observe in the NICU for extremely preterm infants, but it's a sign and it's not a disease. And in this population, babies have rapidly changing physiology, and that often translates into rapidly changing vital signs, including blood pressure. That makes it difficult to identify when to treat a low blood pressure or not. And that's translated into wide variability in how this is done across NICUs. If you look at the data and review the literature, there is some evidence that commonly prescribed antihypertensive therapies are associated with adverse effects, such as death, intraventricular hemorrhage, retinopathy of prematurity, and neurodevelopmental impairment. There are also some studies which suggest that outcomes are similar for infants with low blood pressure who are treated versus untreated infants. There's not a whole lot of data out there to suggest that antihypertensive therapies prescribed in the immediate postnatal period for extremely preterm infants improve any clinically important outcome. So with that premise, a reasonable approach would be to look at low blood pressure in the extremely preterm infant as one important aspect in the hemodynamic management of these babies. In infants with low blood pressure who also clinically appear to be in shock, such as modeling metabolic acidosis, prolonged capillary refill, therapy seems warranted because the likelihood of a bad outcome is very high. And I think we would all agree that such infants should be treated. Again, low blood pressure is a sign though, not a disease, and there's a broad differential for this sign. So when treating infants with low blood pressure and poor perfusion, all aspects of the differential should be considered, and therapy should be tailored towards the most likely diagnosis, given all aspects of the history and physical exam. For infants with low blood pressure who appear to have adequate perfusion, the situation is a little bit different. This encompasses most babies with low blood pressure, sort of irrespective of how you define low blood pressure. Again, there's the same differential, and if there's a high likelihood of one specific disease being the cause of low blood pressure, then it's reasonable to consider therapy. However, in the face of adequate perfusion, low blood pressure is much more likely to be physiological rather than pathological. Since antihypertensive therapies have been associated with a number of adverse outcomes, and the data supporting their improvement in outcomes is unclear, it seems like a conservative approach to blood pressure management for infants with low blood pressure and adequate perfusion is more reasonable than an aggressive treatment strategy. So we looked at fluid boluses, blood products, dopamine, dobutamine, and hydrocortisone. And irrespective of which therapy we looked at or which combination of therapies we looked at, outcomes weren't improved with any antihypertensive therapy or any combination of antihypertensive therapies, irrespective of which definition of low blood pressure we investigated.